Have you had to go to the hospital lately, or have you been there with a loved one? Well, this episode, we're talking to Dr. Julie Siemers, and we're talking all about that patient care and what to expect when you're in the hospital. Not only that, she's going to talk to us about how to survive your hospital stay if, by the off chance, you have to be there for an extended period of time. I don't know about you, but I have heard of a lot of horror stories when people go into the hospital of things happening, accidents happening. And Julie's been in this industry for years and years and is the expert on how to survive your hospital stay. Dr. Julie Siemers is a patient safety consultant. She's the industry nurse leader and educator. She's also founded LifeBeat Solutions and is the author of this best-selling book, Surviving Your Hospital Stay, a nurse educator's guide to staying safe and living to tell about it. Dr. Siemers holds a Doctor of Nursing Practice degree, and she brings more than 40 years of experience and expertise in nursing practice, education, and executive leadership to the healthcare arena. I'm excited to talk about this. Let's welcome my special guest, Dr. Julie. Recently, I started a new Netflix series called The Resident. I don't know if you've seen it, but it's basically the story of these residents that go into hospital and about all of the things that happen behind the scenes, some of the illegal things that seem to happen, some of the sketchy things. And you go into a hospital thinking and feeling like you're going to be taken care of, that everything's going to be safe, that you're going to get the best care. And hopefully you do. And probably you will. But oftentimes there could be things going on that we just don't understand or we don't see. And that could inevitably lead to, a worse outcome than when we went in. So when I got approached by you to have this conversation, I thought this was such a great thing to bring to our audience because we are women, men, over the age of 40, typically speaking. So a lot of us are in menopause and beyond. So that means we're aging, we have aging parents, and the chances of us possibly ending up in a hospital in the next, 10 to 30 years is probably good. Hopefully not. We all take care of ourselves as best we can, but there is the chance that we might. And so I wanted to bring you on because I thought, who better than to ask the expert who has been researching this for the better part of 40 years. So welcome to the podcast, Dr. Julie.
Thank you so much. Thank you for having me. Happy to talk about these important issues.
So I'd like to start with just you have a book called Surviving Your Hospital Stay. Tell us what prompted you to write that book in the first place.
Yeah, so as you said, I've been a nurse for, over 4 decades, and I didn't realize until I started researching my master's degree, my thesis, and then carried that into my doctoral degree, that actual harm was happening in the hospitals as it is. And so what I decided was that the average patient family member needs to understand what goes on in the hospital and how they can become an advocate for themselves and their loved ones, because, medical language is like a foreign language to many people. And the intimidation factor of being in a hospital is a scary environment, but especially if you've had a diagnosis that's going to land you in the hospital, because nowadays you don't go to the hospital unless you're really sick or need a big surgery, right? So I thought these patients and their families really need to understand what is normal, when to speak up, how to speak up, and how to engage with the healthcare team so that, as you said earlier, we can have the best outcomes, because it's not guaranteed. We think it is, and I know healthcare providers, nurses, physicians, they all have the best of intentions, but unfortunately our system is quite broken.
Well, what has happened with the system? Why is it broken?
Probably when in the 80s, when healthcare became a business rather than, the old-fashioned doctor really caring about you and your family. And now the insurance companies, and I know that's been all over the news recently, it's really come to light how much influence they have on what we can and can't do for preventative health, what is or isn't covered, what drives the healthcare system internally from that business model is really quite scary when you dig a little deeper and learn things I didn't even know.
Yeah, I have definitely heard that the hospital is a business as well. It's out to make money for, the corporation. How do we advocate for ourselves then, I suppose, if we do find ourselves in the situation where we're in the hospital and we keep that sort of in the back of our brain, this is a business, but we want the best optimal care. What are some of the things that we can begin to do to, as you said, speak up for ourselves?
First thing is to get educated and informed. And it doesn't mean you need a nursing license or a medical degree, but understanding normal vital signs, understanding what questions to ask about, for example, your medications. What is this supposed to do? What is it for? What should I watch for? And really becoming your own advocate, because we don't have a centralized model anymore where one provider is taking care of us. And so we have to be the one that takes notes, that keeps things organized, that understands our own physiology and body, and therefore, what are the interventions that are being suggested? Get second opinions. I mean, I can share with you, I have a free patient safety guide, and then you can share it with all of your listeners too, that just has some basics on there,
So what sort of basics would you be talking about?
like how to pick a hospital.
Oh,
And if your insurance coverage allows you to pick two or three different hospitals to go have your surgery at, there is a website called hospitalsafetygrade.org, and you can look up. It's sponsored by a nonprofit organization called Leapfrog, and you can look up and see if your hospital is an A, B, C, D, or F, just like college or high school grades, right?
okay.
It's based on 22 categories, five major categories, and then subcategories of actual patient safety data. So, for instance, the surgical category, I think there's six or seven subcategories that you can go in and see if that hospital is, each subcategory is red, yellow, green. So is that hospital doing really well to prevent postoperative blood clots? Are they red, yellow, or green? Or is this hospital doing really well on hand washing? Where do they rank for healthcare acquired infections? You can see all that on the scorecard. I can tell you that the data came out a couple of years ago when I was researching this, that if you go to a D-rated hospital versus an A, your chances of dying or experiencing harm is over 91% higher. So it does matter where you go and how, who is treating you, who is taking care of you.
Now, I wonder if that is the same in Canada. I live in Canada. Is that an American scorecard or is this something that is,
As far as
international?
I know, it is. Anyone here in the US can put in your zip code, but I would definitely write Leapfrog and say, the organization and say, is there anything in Canada that is similar to this?
Right.
If
Uh,
not, they should be going that way too, right?
Oh, for sure. I didn't even think that you would choose a hospital. We, in the city that I live in, we only have one hospital. So
Mm.
what do you say then if people are in a smaller town, smaller city, what could they look for in that case?
I would still ask those questions if it's even just one hospital and say, I'm going in to have surgery. How do you prevent blood clots? Do you use evidence-based technology? And that would be compression stockings and what we call pneumatic hose, which is the plastic sleeves that go on your lower legs and squeeze, so it keeps the blood flow going. And then therapeutic or it's the anticoagulant medication that's given for bigger surgeries, where the patient's mobility might be decreased for a day or two or three. And those are just preventative measures that have been shown to prevent blood clots. So I would ask those questions.
So hospitals then are rated A, B, C, D, and F. A, B, C, D,
Correct.
and F. Right. So do you tend to see specific hospitals in specific demographics have a lower rating, like an F score?
Yes, funny you should ask that question. They come out with their annual report, which just came out a couple of weeks ago. Florida has 3 F-rated hospitals. Utah, I believe, is the highest state with the most A-rated hospitals. So yeah, demographics will make a difference. Yeah.
Right. So why would Utah, like you think Florida has so many retirees, so many seniors living there? I would think they should have better measures set in place. Utah, you've got Reno, you've got oh no, that's Nevada. But Utah, yeah, what would be about Utah that would make it a better place?
It's interesting. And again, it's going to be leadership to me. Leadership makes the decisions. They set the bar, they set the expectations. And I'm actually reading a book right now that's so interesting. It was written by Michael Millinson back in 1997, and so much of it still is so applicable today. But in there, he's talking about LDS Hospital in Salt Lake was really the forefront of cutting edge of doing evidence-based research on randomized controlled trials, which is the gold standard. Is this really effective, and does this work? Or is it just because 3 doctors said, yeah, I like that procedure, I'm going to go ahead and use it, rather than based on evidence or science? So I don't know, maybe Utah has set the stage for, if you get one high performer, the others kind of, I think, tend to follow along,
Mm.
versus poor performers. Maybe it's the same sad case.
I find that there are a certain subset of people who, we would look at anyone who is a professional, a doctor, a teacher, a dentist, a lawyer, and we would say they are the professional, they know best. Who am I to question, them? And yet at the beginning, you talked about really being an advocate for ourselves, speaking up for ourselves. I feel like there are certain people who just will never do that. They weren't taught to do that. They don't have the perhaps skill or the courage to do that, and so they just rely on the doctor. Do you find that's the case? There are some people who will definitely say, "I not demand, but I request this test, this test, this test." I feel like I'm in that camp. And then there are a subset of people, and I think of people maybe more my parents' age who just trust the doctor and don't think to ask for anything except for what the doctor or the hospital recommends.
Yeah, so on my social media, I try to educate, whether it's, my TikTok gets reposted on Instagram and Facebook or whatever, but I try to at least do one every day where I'm making the public aware, unfortunately, of bad things. For example, the other day I posted a man in Montana was given the diagnosis of cancer and underwent 11 years of chemotherapy and found out he never had cancer. And this hospital was investigating this doctor, but because this doctor was so wealthy and he worked the system, Dr. Weiner was his name, he had up to 70 patient contacts every day. And his patients loved him because they could always call and say, hey, blah, 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 blah. And he'd answer them and then he'd bill for it. So he was making over $2 million a year on many, many false diagnoses of cancer. And so, even when this all came out in the news, his patients, his followers, like posted this whole Facebook group on how to support him, and that can't be true. And it was, but they thought he was wonderful because he always answered their questions, or they could ring him every day, or, any time of the day or night. So I think that we have to take off these rose-colored glasses and, yes, most doctors don't want to harm. That's just not why they went into the profession. And there are nefarious situations such as that. But if I'm going to undergo something as serious as chemotherapy, I want a second opinion. And that is your right as a patient to have a second opinion. Any kind of surgical procedure. And here's the other thing, physicians, the amount of medical information that comes out, we can't keep up with. So that's another reason to do your own research. Let's just say you get a diagnosis of endometriosis. It really behooves you to do your own research and find out what is the latest evidence-based technology or evidence-based science, treatment, et cetera, and not rely on doctors because they can't keep up. It's not that they don't want to give us false information. or, they're not trying to harm us for sure. But the average time an American physician, anyway, I don't know about Canada, spends with a patient is 6 minutes. So how can they learn about you, your symptoms, your history, your medical history, your family history, to really come up with a plan that is right for you if they don't have the time because of insurance premiums, et cetera, at least here.
Yeah. No, I think it's very similar up here as well. So it sounds like there's definitely some skills that we could develop to be our advocate for ourselves. You talked about research. I find that so much right now in this menopause space, especially around menopause hormone therapy, what to take, who's eligible. Because, like you said, I go to my doctor and he's not an advocate at all, but he's one opinion, right? And
Right.
when we go online, we listen on Instagram or TikTok, there's just multiple opinions from everyone who's a wise doctor, it appears, and it's just can be really confusing to know. So being your own, doing your own due diligence, I think is
Yeah.
really important. Um, you said something else as well. When my dad had cancer, we were all super concerned. He had never been in a hospital one day in his life. And then at the age of 80, he developed cancer, lymphoma. And so there's three daughters, and all of us were in the doctor's office. All three of us. Yeah, we all had to be there taking notes. My mom was there as well. I'm sure we were slightly overwhelming for the doctors, but we didn't care. I'm like, I don't care if you don't like this, because we want to do our best, and we know our parents are seniors, and while they're smart and wise, again, there's that thought that they just wouldn't speak up for themselves or ask the questions that maybe I've learned to ask. So, what other skills can we develop to be the best advocates for ourselves that we can be?
And you brought this up too, but communication is huge. And so for your listeners that don't want to speak up and are of that generation, think about the cost of not speaking up. And I'll give you an example. We
Mhm.
had, when I was in the hospital with students, taking care of patients and teaching them, we had a patient that had come in. She had knee surgery 2 days prior. She was discharged home on her medications. They said continue home meds as usual. And that just means continue everything you were taking. And then here's the new medications that you need to take when you get home. And her family did not ask, but they wondered, why is mom getting another anticoagulant? Because she takes one for her heart. She has a history of atrial fibrillation, so she takes a blood thinner for that. And then she was given one that's typical for postoperative surgery, knees, hips, etc. So she was double dosed because they didn't speak up and ask.
Mhm.
She ended up back in the hospital now with what we call compartment syndrome because she bled in that surgical site and almost lost her leg because it cuts off the circulation. So we have to think about, if we don't ask, what could be the outcome and the repercussions. But you're right, it's a medical hierarchy that we've lived in this culture for a very long time. That doctors are, when I was in nursing school, it was this picture of them on a pedestal almost as God,
Yeah. Yeah.
that we don't question them.
No.
But that's so many times have been the bad outcome of a patient if a nurse doesn't speak up. I know the Joint Commission, which is big here in the United States, has mentioned several times in their research that 70% of patient harm is due to communication breakdown.
Mm.
That means either between the healthcare team themselves or the family and patient and the healthcare team. So it goes both ways.
Right. So, communication, taking notes, diligent note taking,
Absolutely. Yep.
right?
Yep.
Um, yeah. And I know we did that with my dad as well. We would just, log everything, right? Symptoms, medications, so that we had an accurate track. I'm doing that currently, even with my blood pressure. I have a little chart. I track it so I know what is normal for me. And if it goes beyond normal, then it's something to, raise a concern about.
Right.
One of the things I did actually appreciate about my doctor not too long ago is he said to me, "What else would you like me to do for you?
Mm,
What other tests do you think that we need And while I'm not obviously the doctor, I've done what you said is do my due diligence and do some research. So what are other people doing? And I mean, now with TikTok, my goodness, you can look up any disease that you have, or issue that you have, and then you can see what other people have been doing. I think that can get you down a rabbit trail that might not be accurate and might cause more fear.
Yeah,
But I also think that it's nice that we have that, or it's nice that we have Chat GPT and we can put all of our symptoms and just say, what would some potential tests be that could be causing this? And
right.
this happened to me just over the holidays. I had an instant spike in blood pressure from 110 over 65, which is normal for me for my whole life, to all of a sudden 150 over 95. And I could feel it. It was very palpable in my body, in my head, my hands. And so, I'm like, okay, that's not normal. And going to the doctor, going to the hospital, and they're all like, oh, we've done every test. What other tests would you like us to do? Because we've done it all. I'm like, well, scan this, scan that, because I again threw it into chat and said, what else could this be? Well, it could be this, it could be that. When do we get to like going down the rabbit trail to fear and reality? A little bit I felt like I was following the fear path because I didn't want anything to be wrong and I wanted to do my due diligence. Is there balance between those two things?
Well, I think you said one thing really important about that, and that's sustainable. So a random, spike in blood pressure could be, as you probably learned, from multiple things. And your baseline, though, at 110 over 65 or whatever, completely normal and great. And so it would be, okay, well, what caused this? Was it anxiety? Was it, something bizarre and not going to happen again? But that's what I teach patients in the book too about vital signs or in my social media is just if it's sustained, then we definitely have to dig deeper and figure out what's going on. For example, normal heart rate for an adult is 60 to 100. I mean, that's quite a range. But, if mom's heart rate is 110, for the last hour, and now it's 115, and we're watching it because she's on a monitor in the hospital, or we're checking it because we're really concerned about her, that's the red flag that we need to address. What's going on? Is she in pain? Is she hypovolemic? Is she bleeding somewhere? All of those things that we would want to investigate further. So I think that's probably a word of advice is just, kind of watch it, monitor it. If it's something critical, like dad fell and hit his head and an hour later he's confused,
Yeah.
that's a big deal, right?
Yeah. Acute versus that chronic. How long is sustained? Because oftentimes I think many people will go to the hospital and they'll, get diagnosed with whatever it is, maybe fever, maybe higher blood pressure, and they'll say, just keep an eye on it and come back if it gets worse. I feel like that is the worst solution to go home with.
It's so vague, right?
It is.
So it would depend on what the symptom is. If we're talking about neurological changes, they say anything over 10 minutes. If grandma's confused and she never has been before, then we need to start digging in. If it's a headache or a fever, obviously it's going to be a little bit longer, that we're going to give it to, is it going to resolve? Is it worse or is it better? And then we look for coordinating symptoms that go with it. So if there's a headache, is the blood pressure high? I mean, because that can cause a headache too, right? Do we now have blurred vision? That could be pressing on the central nervous system, something going on in the brain. So again, it's just collecting, as you said, taking notes and writing things down and trying to coordinate all those things to create a picture. And that's what the physicians are really supposed to be doing. So I guess advice for the listeners would be to make your symptoms as concise and trackable, and keep those notes, keep a log, and say for the last 3 days, this has been my weight gain or my shortness of breath, my, anything that's correlative that can create and paint a picture.
Yeah, that's a great tip. What's the biggest hospital safety myth? There's some hospital safety myths going around out there.
Healthcare acquired infections are huge. They kill so many people every single year. In fact, I was just writing again another social post about E. coli now being the biggest contributor to sepsis, which is massive infection that can kill. And they expect, because of the multi-drug resistant bacterias, they expect the increase of those um, bacteria resistant medications, you know what I'm trying to say, the bacteria that are resistant to medications, to get between 3 and 6 million, increase that much over the next years. So infections are huge and easy, really. Have everybody coming in the hospital room, wash their hands. I don't care who they are,
Mm,
doctor, nurse, phlebotomist, respiratory therapist, if they're going to touch the patient or even touching any equipment in the room, they should be washing their hands.
mm.
And yet it's not done nearly as often as it should be, because that could eradicate the hospital-acquired infections by a huge percentage.
So, could you ask someone who's come in to see you and you notice they haven't washed their hands? Do you just say,
Yes.
"Oh, excuse me, could you please wash your hands?"
Yes, I've
Yeah.
done it. I did
Okay.
it last spring when I went to my dermatologist, just to his office. He was going to do a biopsy. The medical assistant set out all the equipment. He walks in the door and starts coming over to the tray
You're
to
like,
pick up.
uh-uh.
That's right. And he looked at me like I had two heads. And I said, "Hey, I work in healthcare. I know." And he goes, "Well, I just washed my hands coming out of the other room." And I said, "But you just walked in here."
Yeah, and you
He
touched the
did it.
handle and yeah, I didn't
Yeah.
see and
Yeah. So if
okay.
more patients would do that, they would have to comply with what we learned in nursing school and medical school 101.
Yeah. Yeah, again, it's that hierarchy thing where you think that you don't have a say, you don't have the right to, request something like that from someone who's in that position
Yeah.
of authority, but it's your life, it's your
Right.
safety. That's really interesting about infection. I'm sure a lot of us have watched Netflix shows like Outlander and how infections just spread back in the 1800s and 1700s because they didn't wash their hands or they would be smoking in the, surgery,
Yeah.
whatever, that's kind of how it was. And now we think, well, everything's so sterile, it should be just fine. Like sponges aren't left in people anymore. And that's a thing of the past. But what I hear you saying is that there's just still that margin of error and there's room for those mistakes to happen. And I mean, when we're out and under, what do you do then? I mean, we have no control, but again, you see some of these things on TV and I know they're exaggerated, but you
Not
wonder
necessarily.
not really? Oh my gosh,
No.
see. Well, yeah, how safe can we be when we're actually under the knife then?
Right. Well, I think interviewing your surgeon, interviewing your anesthesiologist to say, "Hey, I want to talk to the guy putting me to sleep." But when you mentioned surgical instruments, it's 8% of what we call never events that still happen every day. It's like 40 times a week across the US anyway. There is a surgical instrument, a surgical needle, or a surgical gauze sponge left inside a patient. So there is something called a surgical checklist, which the World Health Organization developed quite a few years ago. Only 69% of the hospitals in the US use them. Don't ask me why. They're supposed to prevent cutting off the wrong foot, which happens, taking out the wrong kidney, which happens. But these surgical checklists in this study, they found that 80% of the people that returned to the hospital with sustained pain or infection, and they come to find out had a foreign body left inside them, 80% of those cases had the correct count on the surgical sheet. So for instance, if there's 200 sponges used, they have two people that are supposed to count them all and sign their names that they have the correct count, but 80% of those were correct and still found something inside the patient's body.
Wow, that's crazy
I
and
know.
scary. You said interview your anesthesiologist or your doctor, your surgeon. What sorts of questions could we come to our surgeon with if we were about to have surgery?
I would definitely ask. So a lot of people don't know this too. In the US, at least, there's surgical residents. There's the main surgeon. So I would ask, who's doing my surgery? Are you going to do it? Or is the surgical resident going to do it? And are
Right.
you staying in the room the whole time?
Can you say, I don't want the resident? Like, I
Yes,
remember
you
when I
can.
had my third child or whatever, and they had, a resident or a newbie doctor in there, and they're like, oh, can she feel up, to see how
Yeah.
dilated you are? At that point, I didn't care for her at all. But the other day, I had blood drawn, and they're like, oh, this is someone new. I'm like, oh, no, thanks. I'm already super queasy to get my blood drawn. I want the total professional. I want it one and done. And they're like, oh
Yeah.
yeah, no, no worries. So could we say to the
Yes.
surgeon, we want you, not them.
Yes.
Okay. Okay.
Yeah. They can watch, but I want you doing the suturing, whatever it is, the exploration, whatever,
Yeah.
surgery is going on.
So we,
Um,
oh, go
yeah, go
ahead.
ahead. No, go ahead.
So we can say who's doing the surgery. Yeah. Can we
Yeah,
ask their years of experience and how many
absolutely.
botched botched surgeries they've had?
Well, unfortunately, it's really hard to find the data. The medical community protect their own, so it's really hard to find data on botched surgeries.
Mm,
But there is data supporting that, for instance, if one doctor did only 25 prostatectomies this year and another doctor did 250, their success rate is much higher the more they do, which makes sense, right? So I would not pick a surgeon that has not done that many of them.
yeah.
Uh, I would do my research on that piece of it for sure.
Mm,
That's going to make a big difference. You know, the good thing with older physicians is, or more experienced, they have more experience. The
yeah.
younger doctors may have been exposed to more modern technology, but I think the blending of the two is probably where your sweet spot is. And so those are the questions I would ask, like your older physician, if it's any kind of therapy, because things change. Are they using the latest technology or evidence-based research?
Yeah, there is that. You're totally right about that. We sometimes rely on the seniors because they've been in it for so, so long. But then, in my brain, I think sometimes I want someone brand new because they'll know all of the current research or the current procedures or the current ways to do things. So, yeah, sort of both and, I suppose.
Yeah, it'd
Yeah.
be nice to have a blend. But even textbooks, and I can't remember where I heard this, are at least 10 years behind of current research. So even coming out of medical school, they're behind. And it depends. I mean, they're definitely have to keep up continuing education, but what kind of conference are they attending and what kind of talks are they listening to get those continuing medical education credits? Is it relative or related to their specialty, you know?
Hmm. What else do you talk about in the book? So you definitely give patients the ways that they can develop skills to advocate for themselves. What else do you discuss in your book?
So there's about 30 stories in the book, and unfortunately, most of the patient stories are patients that have died. Some were just severe harm. And I think I'm a story person. I relate to stories. And so, the purpose was to talk about a topic such as tube feedings, for example. If your grandma has a stroke and she can't eat, but we know they need nutrition, they'll put a tube down the nose and, feed directly into the stomach. But there are risks with every procedure that we do. So one of the risks for tube feedings is aspiration, where the tube feeding maybe is not absorbed as quickly as it should be, especially when things slow down in our bodies after a stroke, for example. And that tube feeding can actually regurgitate back up and it can go in the lungs. That's what aspiration is. So to prevent that, the head of the bed of the patient should never be flat. And
Mm,
yes, on occasion, nurses will put the bed flat if they're doing a bath and changing the sheets, but the tube feeding should be shut off during that time. And then the head of the bed should be back at least 30 degrees to prevent aspiration. And so I believe the story, I tell it anyway, I would think put this one in the book, was my clinical coordinator, actually, one of the schools I worked at, her grandmother was in this situation. She didn't know the head of the bed was supposed to be up, and grandma was flat, aspirated, got pneumonia from that aspiration and died. And so it's just how do we prevent those little
Yeah.
things? And they're not little, they're big, but
Yeah.
that's a family member, how you can advocate and watch out. So it's again, just getting informed, go to the part in the book, okay, my dad just had, brain surgery. What should we be watching for? Or my brother had chest surgery and now he's got a pain pump. What should we be watching for? And that one, anybody on opioids, but especially IV, continuous drip, counting the respiratory rate. Respiratory rate is the single and earliest indicator of patient deterioration. So
Is that your
anybody,
heart rate?
the respiratory rate is how fast you're breathing.
Is that heart rate or beats per minute? Different.
No, yeah,
Okay,
it's
just so you would
so,
just visually note how fast they're
yep.
breathing.
Yep,
Okay.
you just watch. You don't tell them you're doing it because it's weird when they know you're counting your
Yeah.
respiration. They can't breathe
That's right.
right. But you just watch the rise and the fall of the chest, and you do for 30 seconds times two or full 60 seconds. Normal respiratory rate is 14 to 18. Anything lower, we want to keep monitoring. Anything higher, we want to keep monitoring. So the lower rate we would watch for anybody receiving opioids, because what happens is the carbon dioxide builds up in the blood when we're not exhaling or not breathing fast enough. And so that then causes its own problem of the patient gets, we call it CO2 narcosis, where they lose the drive to breathe and their respiratory rate can fall from 12 to 10 to 8 to 6 till they stop breathing. And so if we're not counting, and 80% of the nurses don't count, they just write down a number. It's a vital sign. It's called vital for a reason. It's
Mm.
important.
Right, right.
On the other hand, if they're breathing 20, 22, 24 times a minute, we need to keep our eye on that also because that can indicate the cells are not getting enough oxygen. And luckily, our autonomic nervous system says, hey, we need some more oxygen here at our cells. We need to breathe faster. We don't think about it, right? It just happens.
Mhm,
But that, again, is a really early indicator of patient deterioration.
mhm,
Something's
mhm.
not right, and we need to figure out what it is.
Right. Well, I love that you have those stories within the book because I think we all can relate with that, right? And I like that you said, if you're having this type of surgery, find this section, see what there is to look out for. And I think that can really help educate us and help to protect us in the long run. So I love that. I think that's great. Your book is available probably anywhere that books are sold or Amazon. Yes?
Yes. Uh-huh.
Okay. I'll definitely link that in the show notes, everyone. Could you tell us where people can follow you? I did watch a number of your TikTok videos. I think they're super educational. So you're on TikTok, and what are your handles on TikTok and Instagram?
They're all Dr. Julie Siemers, Siemers. And then my website too. I've got a lot of blogs that I post about different types of interesting articles, and I'm also on LinkedIn. So
Wonderful. Awesome. Well, that was super informative. Thank you so much, Dr. Julie. I appreciate that. Knock on wood, we won't be in a hospital anytime soon, but if you are, or if one of your loved ones have to go in, definitely follow Dr. Julie, get prepared ahead of time so it's not like in the moment, right? I think it's always best to fix the roof while the sun is shining, says JFK, and preparing yourself for what might happen, I think is a good idea as well.
yes, for sure. Thank you so
Well,
much for having me.
yes, thank you for joining. As always, everyone, go move daily now in your fitness, wellness, and nutrition, and we'll see you all in the next Move Daily Talks.